Welcome to part 2. This is the reading test for amyloid PET brain imaging, brought to you by the Australian Dementia Network. And I'm Chris Rowe, and this was prepared by myself and Dr. Naomi Shea. Now, what you're going to be tested on is NAV4694 amyloid PET imaging. This tracer is widely used in research and in some clinical trials, but it is not FDA or TGA approved. If you're going to be reading the FDA, European Medicines Association agency approved tracers such as Vizamyl, also known as flutamidamol, or Neurosec, also known as florbetaben, or Amyvid, also known as florbetaper, then it is best that you do the official training program that is provided by the producers of these tracers. To do the Vizamyl flutamidamol training program, this is the website to go to. You can select your country. You need to enroll, put in some information, and after enrolling, you can return to the training at any time by selecting login. For Neurosec, similar process, although in this case, you do need an access code for many of these training programs. So email reader training at Life Molecular Imaging. That's the company that supplies Neurosec. Once you have your access code, then register, complete the information. Away you go, hit the play button, do the training. There are 7 training modules for this program. When you've completed the training modules, you then undertake the final assessment. You have 3 chances to pass the assessment, and you require 80% correct or greater to pass. And once you've passed, you can download a reader training certificate documenting that you have passed the training program for this tracer. Similarly, for Avivid or florbetaper, this is produced by Avid Radiopharmaceuticals, who are a subsidiary of Eli Lilly. Go to amyvid.com. You have to indicate that you're a health professional and select the reader training, fill in password, etc. And at the end of the training, again, you can save a completion certificate as documentation that you've done the course. Now, these courses are designed for health professionals in the countries where these tracers are approved. So there can be some hurdles to get across to access these training programs from Australia. But today we're looking at NAV4694 amyloid PET imaging in part A. I will show each screenshot. So there's 1 screenshot per case or per example. I will pause for a couple of seconds, and then you should hit pause on your player and then read the scan as either negative or showing mild binding, and that includes equivocal cases, moderately positive scan, or a highly positive scan. There are 30 cases, and when you've done this for your 30 cases, this is followed by those cases being represented with my commentary and my interpretation and the Centiloid result. This is not an official training program. It's largely based on my personal experience, which is of several thousand amyloid images. So it's an educational material. It's not a authorised or government authorised training program. However, the rules that apply for reading, or the techniques that apply for reading NAV4694 do apply across all the tracers. So once you've mastered one, you should be quite competent with the others. Having said that, because florbetaben and florbetaper are read in grayscale, and those tracers have lower affinity for amyloid plaques in the cortex than NAV or PIB or flutamidamol, they can be a little bit more tricky. and they won't look as floridly positive as a strongly positive NAV scan, for example. So your threshold for calling something moderately positive would need to be lowered when you're reading those traces. So for this little assessment, I have set 100% as being the pass for getting, if you've got the negative cases, 100% correct, and the moderate or highly positive cases 100% correct, then you've passed. However, mild binding scans are not rated. In clinical practice, some readers will call them negative, some readers will call them positive. Doesn't matter a lot, because mild binding in symptomatic persons presenting for diagnosis of Alzheimer's disease is likely to be asymptomatic due to the high prevalence of amyloid in the population over the age of 65. You really do need a moderate to high amount of amyloid to support a diagnosis of Alzheimer's disease. So if the scan is only mildly positive, it should be alerted to the referring clinician that other causes for the patient's cognitive presentation should be investigated. And while Alzheimer's disease may be a contributing factor, is unlikely to be the predominant cause of the cognitive decline. However, for early detection for research or trial purposes, mild scans do need to be accurately separated from negative scans. So there are some mild scans in this training program. So here's the first case. And now every 4 seconds I will move along. No commentary at this time. I want you to pause on each image and give it a rating of negative, mildly positive, moderately positive, or highly, in other words, strongly positive. So I'll just flick through the 30 cases now. Thought I'd finish on a fairly straightforward case just to rebuild your confidence. I have selected a lot of equivocal or mildly, moderately positive scans, more than what you see in clinical practice. Fortunately, in clinical practice, most scans are either clearly negative or quite clearly positive. And it took me quite a while searching through all our various scans to find some more challenging ones for this application. So the answers. Case number 1 is negative. The centiloid score is -5, just like the Celsius temperature scale, although it's set between 0 and 100. You can go negative and you can go above 100. So this is clearly negative. There's good space between the hemispheres. There's no kissing of the hemispheres, particularly in the medial parietal or precuneus cortex. There's no uptake in the frontal lobes. There's no smoothing out of the edge of the cortex because you've still got the white matter. This is a bit of a young brain appearance. In younger brains, there appears to be more white matter, and it can give a bit of an impression that there might be something going on. But in younger patients, no, this is just all white matter. So in an older patient with a partially atrophic brain, the finger-like projections in a negative study are more obvious than they are in younger patients. So that can be a little trap. Don't overcall. And again, another good reason for not calling equivocal scans positive. There's no uptake in the striatum or caudate nucleus region. And basically, it's a negative scan. This one is highly positive. Centiloid score is 125, and in this case, there is clear intense binding in cortical areas, particularly the frontal lobes, precuneus, posterior cingulate region, parietal cortex, the anterior striatum, caudate nucleus, very easily seen, lateral temporal lobes. The colour scale has been set appropriately. There's some red appearing in the cerebellar white matter, but there's no uptake in the surrounding cerebellar grey matter. So good quality scan, clearly highly positive. Clearly negative scan. Colour scale has been set appropriately. There's a little bit of red appearing in the cerebellar white matter, but there's clearly no evidence at all of cortical binding. So as opposed to the first case, this is more obviously negative. It's probably an older patient, even though the centiloid scores were both similar. This one is very easy to read as a clear negative. This one is a high positive. The centiloid score is 95. There is binding in the medial temporal regions and parietal cortex, frontal lobes, the striatum, the anterior striatum, and the lateral temporal lobes. A negative study, centiloid score is -5. You can see there's just white matter binding, but there is a lot of extracerebral activity here. There's a lot of activity in the venous sinuses, indicating that there has been either slow clearance of tracer from the blood or alternatively rapid metabolism, leaving radio-labeled metabolites that don't cross into the brain in the blood pool. So this is the superior sagittal sinus. So there's activity in blood pool there. Here we can just see a little bit of inferior sagittal sinus, and there. And then coming right down, we get into the transverse sinus. And there's a lot of facial activity. And in fact, there's probably jugular vein activity as well. So a negative scan, even though this is not the highest quality scan, it's still clearly negative. Another negative scan, centiloid score in this one is 8. Again, it's a slightly fuller brain than some of the negative scans you'll see. And you might think, oh, maybe there's a bit something going on, but there isn't. There's still fingers of white matter. You haven't filled in around the cortex. The rest of the scan is clearly negative. There's no loss of the gap between the hemispheres. There's no activity in the striatum. This is a bit of a fuzzy scan. It's a mild to moderate with a centiloid score of 33. So it's a bit patchy. There's obviously something going on here in the dorsal left frontal cortex, perhaps a bit over in the right as well. There's a bit of blurring coming together of the interhemispheric fissure, particularly frontally. We don't see any activity in the striatum. There is some filling in around the lateral temporal cortex. So it's a bit of a fuzzy one, but there is evidence of amyloid, and you could call this mild or you could call it moderately positive with a score of 33. So in this case, given that the Centiloid score of 20 to 25 indicates there is significant amyloid plaque present, we know there's amyloid plaque in this person of moderate to frequent density. However, a score of 33 is a bit low for someone with Alzheimer's disease. Generally, you need to have a score of 50 or higher to have tau and meet all the full neuropathological criteria for Alzheimer's disease. So this person is certainly well on the way. The amyloid may be a contributing factor to their cognitive impairment, but it's not definitely the major cause. So there's a bit of uncertainty that should be reflected in your report in this case, saying although there is some evidence of amyloid plaques, other conditions still need to be considered as contributing to this person's presentation. Strongly positive. Looks more than 70 centiloids. I would have thought this one was 100. Possible technical reason for that might be that there's binding in the cerebellar reference region. And if that's the case, it lowers the ratio of cortex to reference region. So that SUVR number is lower. When it's converted to the centiloid value, you get a lower value. So we can look around and yes, there might be a bit of activity spilling out into areas where the grey matter reference region's been applied in this case. But it's a clearly positive study with all the classic features. Clearly negative study, Centiloid score of -3. Case 10, moderately positive, could be called highly positive. The Centiloid score is 66. There's clearly marked uptake in the right parietal cortex, a little bit in the left, it's in the precuneus. You've lost the gap between the hemispheres. There's some frontal activity. It is fairly asymmetrical, more on the right than on the left, but there is some on the left, again going down into the temporal lobes, or more right than left. We're not seeing much in the way of striatum. There's a little tiny bit here. The colour scale has been set appropriately. There's some red here in the cerebellar white matter. So this is a moderate, maybe, or almost a highly positive scan. Asymmetry can be seen in Alzheimer's disease. It's not common, but you do see it from time to time. Clearly negative scan in case 11. Centiloid score is -9. Another moderately positive case. Centiloid score is 68. Again, you've lost that gap between the hemispheres. There's activity in the medial and lateral parietal regions. Frontal lobes are smoothed out, so there's activity out in frontal lobe cortex. There's smoothing out of the lateral temporal cortex. We're seeing just a little bit of activity in the striatum, but not much. And the colour scale is appropriately set. So it's a moderately positive scan, and that is enough to support a diagnosis of Alzheimer's disease. A mildly positive scan, the Centiloid score is only 24. And that's because the amyloid, interestingly, is limited to the medial parietal regions. You can see we've lost our gap between the hemispheres. Maybe there's a little tiny bit of frontal, but it's this is almost a purely medial parietal case. So it's mildly positive. not likely to be the cause of somebody's cognitive impairment. The only reservation I have there is that if the amyloid is in the precuneus posterior cingulate region of the brain, it is possible that that is having a greater effect that may be symptomatic than if there was just a bit of amyloid in the frontal cortex, for example. But this one, called mildly positive, but again, say insufficient to make a confident diagnosis of Alzheimer's disease, and other causes for the patient's cognitive complaints should be investigated. Moderate to highly positive, Centiloid score is 85. If you look down in the cerebellar white matter, there's no red. So this should be turned up a bit and it would look a bit more obvious, although it's clearly positive. A mildly positive case, Centiloid score is 13. Again, this is an interesting case in that it seems to be limited largely to the medial temporal region. There's some kissing going on in the posterior part of the interhemispheric space. There's probably a little bit going on in the left parietal cortex, but not much else. The frontal lobes don't really appear to have much amyloid in them, and there's no amyloid in the striatum or lateral temporal cortex. So same again, visually mildly positive. On quantitation, it's negative. But I think given the appearance, there is a little bit of focal amyloid there, but not sufficient to support a diagnosis of Alzheimer's disease in someone with cognitive impairment. Nice, easy one. High positive, Centiloid score 112. Note the sparing of the sensory motor cortical region and primary visual cortex. Well, not in this case. I take that back. This person has clearly got amyloid in their medial occipital lobe. Again, quantitatively negative, Centiloid score of 10. Visually, an unusual case, mildly positive. Just gives the impression there's a bit of filling in of something back here in the posterior parietal regions. As you track that down, the posterior temporal regions also appear to have activity out in the cortex. Again, this is an equivocal case. It's not typical of Alzheimer's disease. In fact, if anything, you'd be a little wondering about the frontal lobes here. There seems to be some loss of white matter in the frontal lobes and up around here. So again, you'd be urging your clinician to investigate for other causes of cognitive decline. Highly positive case, Centiloid score of 92, just the typical features. Mildly positive Centiloid score, though, is only 5, so negative on quantitation, but visually there's a little bit of something going on back here. Some of this is activity in the superior sagittal sinus, so blood pool activity, so don't mistake that for kissing of the hemispheres at the back. But here it just looks like there's a little something going on, and again, the lateral temporal. These areas are a bit non-specific, and overall, I think this scan should really be called negative. Again, an equivocal one, Centiloid score is 17, so quantitatively negative. We know at 17 there might be sparse plaques around. And in this case, what we see is really activity predominantly in the right temporal lobe, which is very unusual to have such focal findings, and a bit of blurring of perhaps the orbitofrontal cortex. But while visually we're picking up a little something here, it's, overall the scan is negative and not supportive of a diagnosis of Alzheimer's disease. High positive, centiloid score is 85. Again, the colour intensity is down a bit. We're not seeing any red in the cerebellar white matter, so this would brighten up with more red appearing if the colour scale was increased somewhat. It's mildly positive, centiloid score of 20. Some people would call that quantitatively just positive. Others would call it still on the negative side. Again, this is an unusual pattern. It's atypical. It's really predominantly in the left parietal cortex, going down into the occipital lobe and the temporooccipital cortex here on the left. Now, we do occasionally see isolated amyloid in the occipital pole. This is a bit more extensive than that. We don't really know the meaning of isolated unilateral occipital amyloid. It's usually negative on quantitation, and whether it's an Alzheimer's process or something else going on is still a little unclear. So an atypical pattern, there's certainly tracer binding, however, so you would call it mildly positive, but stress that it's unusual, and there is not as much amyloid there as would usually be seen in a symptomatic case of Alzheimer's disease, so other pathologies should be examined as they may be, as alternative pathologies may be the predominant cause for their presentation. This one's moderately positive. Centiloid score's 29, so it's quantitatively positive. Mainly activity in the left parietal cortex. There is some loss or kissing of the posterior interhemispheric space. Goes down into the lateral temporal cortex on the left. There's a little bit here in the right parietal cortex. So mild to moderately positive case. Again, some caution in the interpretation of this one. It's not as much as you'd usually see in Alzheimer's disease. Moderately positive case with a centiloid score of 60. We've lost the posterior gap between the hemispheres. There is smoothing out of cortex generally in parietal and frontal regions and lateral temporal cortex. There's a bit of uptake in the left anterior striatum. Moderate positive again, centiloid score of 40. We've lost the posterior interhemispheric space. There's some activity out in the parietal cortex. There looks to be filling in some smoothing of the cortex here in the inferior and orbitofrontal regions. There's a little bit of activity in the anterior striatum and a little bit of activity in the lateral temporal regions. So moderately positive, centiloid score of 40, probably enough to support a diagnosis of Alzheimer's disease, even though it's on the low side, but it is fairly extensive. Moderately positive with a centiloid score of 72. Again, we've lost the gap. We've got definite frontal lobe uptake, so smoothing out of that cortical rim. So the tree in winter appearance rather than the, tree in summer appearance rather than a tree in winter that's lost all its leaves. We're not seeing any fingers of white matter at all. We've got definite uptake in the striatum. So that one's clearly positive, at least of moderate amount, and it is sufficient to support a diagnosis of Alzheimer's disease. This is a moderate or highly positive case. Centiloid score is 82 with uptake in the usual regions. This is a moderately positive case, centiloid score of 55. You can see again the usual posterior midline. There's frontal uptake, there's striatal uptake, and there's some lateral temporal uptake as well. The colour scale has been set appropriately. So at 55, this is enough amyloid to support a diagnosis of Alzheimer's disease in somebody presenting with cognitive complaints. And another moderate case, 52. I won't describe it in detail, it's the usual, but this has got extensive amyloid, just of moderate amount. But again, there is sufficient here to support a diagnosis of Alzheimer's disease in somebody with cognitive impairment. And the last case, just as I mentioned earlier, is highly positive, centiloid score 161. So I hope you've done well. And I want to emphasize again, I chose a lot of difficult cases for this training program. Most of the scans you read in clinical practice are either clearly negative or clearly positive, but it's good to have a feel of those that are intermediate. Again, if you're reading scans other than NAV, because this is a higher contrast tracer than some of the FDA-approved tracers, if you're reading other tracers, you should make sure you've done the manufacturer-supplied training program for that tracer, but the rules are all the same. So the location of amyloid in the brain is the same no matter which tracer you use, and all tracers do pick up amyloid. So they're basically showing the same thing, some with a bit more contrast than others. So thank you for your attention.